Thank you everyone for coming out. Thanks to everyone for spending a big chunk of their weekend with us all here. Thanks for the foundation for giving me the opportunity for putting this talk on. So as Paul mentioned, my talk is on ankle sprains and ankle instability. I do not have any disclosures, with the exception of the fact that I had a lot of childhood heartbreak from the success of Joe Torre's Yankees against my Atlanta Braves. Just got to get that out there. So ankle sprains, this is a very, very common injury. There are tens of thousands that happen every single day in this country, and that amounts to millions every year. And it is a significant health expense for emergency departments, for urgent cares across the country. And the most frequent mechanism of ankle sprains is an inversion force on a plantar flexed foot. And this typically results in injury to the lateral ligaments, which we'll get into on the next slide. And while most of these heal with enough conservative treatment, it is estimated that about 10 to 30% of these will go on to develop what's called chronic instability. So they develop sequelae, significant limitation, difficulty doing activities, and then that's when surgery is potentially an option, which we'll touch on later in this talk. So the anatomy is important, and it is important to focus on the bony anatomy of the ankle here. So in this picture on the bottom, the ankle is an inherently stable joint with where the talus sits inside the ankle mortise. This is in contrast to the shoulder joint, which my sports partners see more, and it's like a golf ball on a tee. And as you can see in the slide or in the picture, there's less inherent bony stability. That being said, the ankle still requires or leans on soft tissue support quite a bit. So you have your lateral ligamentous complex, which is made of the ATFL, the CFL, and the PTFL here. The deltoid ligament complex, which is has a superficial and deep band on the inside or the medial side of the ankle, and the syndesmotic complex that Dr. Pasternak had touched on in his talk as well. And this is what's known as a high ankle sprain. So the vast majority of these inversion injuries involve the lateral ligaments. When evaluating patients in the office, patients will commonly complain of a history of recurrent injuries, of having rolled their ankles a lot. People will talk about their ankles feeling weak, unstable, just giving way. People will talk about hesitation and walking on uneven ground. It is imperative when you're examining someone to always compare it to the contralateral side, because everyone has a different baseline. And then you're able to appreciate just how much more lax someone is on the symptomatic side compared to the good side. So these are two maneuvers that we typically use every day in the office, called the anterior drawer exam, as well as the talar tilt, to examine the laxity in someone's ankle. Imaging, we typically get a set of x-rays to rule out other, like a fracture or associated pathology. And also to assess a patient's alignment on standing. I get questions every single day in the office about this, and MRI is typically not indicated for acute ankle sprains, with the exception of a few things. So conservative treatment is the mainstay of how we treat ankle sprains. This is where we have patients do home exercises. This is where we lean quite heavily on our PT. The picture here is an example of a PT protocol for rehabbing an ankle sprain. I do think the timeline for rehabbing this is quite variable depending on the severity of sprains. We're using boots, brace to immobilize patients, sometimes crutches if they're having difficulty bearing weight, ice and elevation obviously, and that's how we treat most ankle sprains off the bat. And if you go through different forms of conservative treatment, having persistent limitations despite months of treatment, then we start talking about potential surgery if you failed conservative treatment. So typically when we start having that discussion on potentially surgically stabilizing the ankle, despite adequate PT, we typically get an MRI to evaluate and rule out other concomitant pathology. And what are goals of surgical treatment? Like why are we fixing them? So we're trying to stabilize the ankle, we're trying to prevent the ankle from rolling, we're trying to prevent recurrent injury, we're trying to improve function, and also for pain relief. So what we look for on a preoperative MRI is a whole host of things. So cartilage defects, OCLs or osteochondral lesion of the talus. We're looking for perineal tendon pathology. Sometimes it's just tenosynovitis. Sometimes you have a peroneus brevis tear that's associated with ankle sprains that needs to be looked at as well at the time of surgery. We're also looking for any medial-sided ankle involvement as well. So it is not uncommon to have other ligaments involved in a chronic ankle sprain as opposed to just the lateral ligaments. It is very frequent that there's some sort of deltoid or syndesmotic involvement, whether or not they actually need to be fixed surgically. So you just need to be mindful of that and to rule it out on a preoperative MRI. So when we talk about surgery, we'll go through the non-anatomic options and then talk about the anatomic options as well. So this is more historic overview when we talk about non-anatomic repairs. This is where we harvested one of the peroneal tendons on the side of the ankle, the peroneus brevis. And these are examples here in A, B, and C in this picture here where we had procedures called the Watson-Jones, the Evans procedure, or the Crisman-Snook. And essentially these are using either all or part of the peroneus brevis tendon to prevent ankle inversion and to restrict that motion of the ankle to prevent it from rolling. However, as we found out later on, the more and more of these were done, is that they have harmful effects. So you're harvesting a local tendon around the foot and ankle that is essential for stability and using it for something else that's going to significantly alter the kinematics of the ankle. And in addition, we've also shown that range of motion is restricted post-operatively, and these are associated with arthritic changes down the road. So these have largely fallen out of favor now, but just, to get where we're going, we have to know where we came from. So then we get to the anatomic repair. So the Brostrom-Gould procedure here is where we directly address the lateral ligaments, and it was first described in the 1960s. It was first described as an imbrication in the mid-substance of the ATFL. These days typically involve detaching the lateral ligaments off the fibula and then reattaching them in a tighter fashion, as we'll show in later slides. You can also, so the Gould modification to this was where they took the inferior extensor retinaculum, which is this thick band of tissue here, and imbricating it into the repair to augment the strength. And that's quite commonly done these days as well. So this is an anatomic reconstruction. So this does remain the historic benchmark, and there's a lot of studies over the years that support the efficacy. There's even studies at 26-year follow-up, there's great outcomes overall. So this is very, very commonly done now. In spite of that, the failure rate of this procedure is estimated to be anywhere from 2 to 18%. So why do these fail? Why don't they go well initially? So whether it's internal or external factors, are we overlooking someone's alignment, such as the picture on the upper right? Someone have a very high arched foot or cavus foot that's causing what I would term lateral column overload that's not addressed. Does someone have inadequate or are there biologic factors at play? So generalized ligamentous laxity is actually very common among patients with ankle instability, and they can just be more predisposed to stretch out. The tissue quality may not be as good on repair. So when these don't go well, you have to kind of take a look back and say, what can we do to prevent this from happening the next time? So this is where augmentation came into play here, where in addition to the lateral ligament repair that I described earlier, you're supplementing it with an implant. So that the suture tape here where the blue arrow is pointing to, right there, this is approximating the path of the ATFL. It's anchored in through drill holes in the fibula and the talus. And it's exactly what it sounds like. It augments or supplements the repair. It also provides an internal restraint. And there are benefits to this, and it's quite commonly done now too. So our cadaver studies now show that augmentation has similar biomechanical stability as a native ATFL at the time of repair, has a higher ultimate load to failure and stiffness than the intact native ATFL. So because of this, there is the potential to accelerate patients' rehab and they can get back to activities faster. However, I do think there are certain considerations with augmentation. Is it necessary every single time? I think that's a topic for debate. I think if you poll 10 surgeons around the country that do this, you'll get 10 different answers. What if this doesn't work? What is your bailout after that? What's your next operation if this doesn't go well? And with these drill holes anchoring the suture tape or any sort of construct in the fibula and the talus, these drill holes can cause bone edema, they can cause pain, and have lasting effects afterwards. So I think this, you kind of have to take a step back and say, is this really necessary every single time? I would say no. So then we start talking about allograft. So allograft is where it's kind of like our Sports partners where they do ACL surgeries, where they're harvesting one of the hamstring tendons. So in this, we're harvesting one of the hamstring tendons, the semi-T or the gracilis from the knee, and then basically using it through drill holes in the talus, calcaneus, and the fibula to reapproximate the pass of the ATFL and the CFL. And this has been shown to be successful. Our cadaver studies do show that it has similar strength and stiffness to the native ATFL at the time of repair. The indications to do an allograft are in a revision situation or when the tissue quality is poor and it's not possible to do an anatomic repair with the local tissue. It does have some drawbacks though. You are stiffening the ankle. It can limit the motion in the hind foot. It does alter the ankle kinematics, and it has been shown to heighten the intra-articular contact pressures, which can potentially lead to degenerative changes down the road. Then there's arthroscopic reconstruction, which is now a newer technique. It's what I would term minimally invasive. I think all around foot and ankle and a lot of other branches of orthopedics, there's a kick to get into more minimally invasive approaches with smaller incisions, faster recovery, potentially less risk of wound healing issues and infection. Overall, basically this is using arthroscopic incisions to basically do what I described earlier for the repair. But right now, clinical results and data and long-term results are still pending. So I think the jury's still out, although this is becoming more and more popular. So my take on this, after looking through all the surgical options, are generally, I have experience with most of these techniques. I do generally utilize the Brosser Gould repair for most of my primary lateral ligament reconstructions. If I don't augment it, I do try to protect the repair for at least 4 weeks before allowing someone to bear weight, and I'll get into a sample post-op protocol later on. Definitely can consider either augmentation or allograft in a revision situation depending on the patient. Arthroscopic reconstruction, as I said earlier, long-term results are still pending. So this is my algorithm for trying to reconstruct the lateral ligament. So basically, if the MRI dictates, we sometimes do arthroscopy first, done supine, ankle arthroscopy to clean out the joint, look for the cartilage issues that may show up on the MRI. And then I do like to turn the patient lateral for better visualization to do the actual lateral ligamentous reconstruction. Incision-wise, two different types of incisions used. So on the left-hand side, a lot of people do the parallel the anterior border of the distal fibula. I like the lateral extensile approach seen on the right-hand side, which is here. As the name implies, it is more extensile, but I do think it allows more visualization for the lateral ligaments. Allows you to get to the perineal tendons, especially in a revision situation. It's the much preferred incision. And then, so in the reconstruction, you're essentially detaching these ligaments, the ATFL and the CFL. They're as a thick cuff of tissue off the distal fibula, as seen in the pictures. So on this picture on the right-hand side, now the bone is bare. Now that the ligaments have been detached off of it, and they're being retracted by these retractors here. And this is where they previously originated from. And then you're basically drilling anchors in to the distal fibula and using those needles coming off the anchors to tie down the ligaments back to where they came from and to tension them as tight as possible because we know they're going to stretch out over time. And then afterwards, patients are generally in a splint as close to neutral as possible. So here's a sample post-op protocol. So basically, they're non-weight bearing in a splint for at least the first 2 weeks. They're transitioned to a cast or a boot after that. Typically, patients are non-weight bearing for about 4 to 6 weeks on the operative leg afterwards. They can start physical therapy once they start bearing weight. I do like to restrict active inversion because it can stretch the repair out for the first 6 weeks after the repair. Getting back to regular shoe or brace by around 2 months after surgery. Back to sports, running around 4 to 6 months, with full recovery being anywhere from 9 to 12 months after surgery. Depending on other associated pathology like OCL or perineal tendons that may be addressed during the surgery, the rehab may be altered in terms of the time frame. So in summary, ankle sprains and instability is quite a common problem. While the vast majority of injuries can be treated conservatively, surgical intervention can help. There's a lot of preoperative considerations to take into account. And at the end of the day, the best surgical option is a patient-specific decision. Thank you.